Dear Marolings, welcome to this video where we are talking about the psychiatry question which had come in the INI-CET 2024 November. Fortunately or unfortunately, you had one question. So students, some of them who did not prepare for psychiatry would be happy. Some of them would be feeling unhappy about it. But I guess it keeps changing. So we might expect more number of questions in the coming sessions. So let's jump into the question and try to understand what did they ask here. So interesting, very basic, simple question which has come multiple times in exam. But they've asked in the match the following format rather than an MCQ format, where they've given you the drugs naloxone, oxazepam, varenicline, acamprosate, and the other side they have given you smoking cessation, opioid overdose, delirium tremens, and treatment of alcoholism. Treatment of alcoholism, and they've asked you to pair. So let's try to pair these things and try to understand what's the right answer. When you talk about naloxone, I'm sure all of us know opioid poisoning or opioid overdose is where you use IV naloxone, right? IV naloxone, which is an opioid antagonist. What about oxazepam? Oxazepam, if you remember the videos where we have spoken about alcohol withdrawal, in liver dysfunction, LOT, lorazepam, oxazepam, and temazepam are three important drugs which are useful. So patients who are in withdrawal, you can actually use. So you might say it can be used in both of these conditions because it is also part of alcoholism. Let's keep it there. We'll see what happens with the rest of the choices. Varenicline. Varenicline. What is varenicline we are talking about? Varenicline, we know, is one of the very, very important effective strategies in nicotine cessation. In nicotine cessation, varenicline is known to help. Now, what about acamprosate? Acamprosate is used to reduce craving for alcohol. Acamprosate is used to reduce for craving of alcohol. So, with this understanding, if you look at the choices, what is the answer you think? If you look at it, you will realize that naloxone opioid. So, this choice B is the answer for this question. A pretty comfortable question. Of course, delirium tremens and treatment alcoholism has some overlap, but with the other choices, there's not much of confusion with this question. And I'm sure all of you would have answered this question correctly. With this question, we'll also try to address some of the important things which comes because almost all of these things keep coming every year, right? So let's try to understand a little bit more on some of the related questions which can come up in exam. Tobacco cessation or nicotine cessation. When you're talking about tobacco cessation or nicotine cessation, you need to understand there are few things which they can ask in exam. One, there is this brief intervention which they can ask in exam. What is this brief intervention we are talking about? The brief intervention we are talking about is called as 5 A's intervention. 5 A's intervention. What are the 5 A's? A, 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 A. So what does it stand for? You should ask every patient of yours, whether you smoke or use nicotine in any form or the other. You should ask all of them. So some of them will say yes, some of them will say no. Some of them will say little, occasional, sometimes, too much, whatever it is. All those who say no, you leave them and say, great that you're not using, never use it again. But anybody else, you should always recommend them. You should give an advice for them to stop nicotine in an assertive way. You need to advise them. That's the second A of the brief intervention. What is the third A? The few who have told, yes, they do smoke and those things, you would want to assess further, right? What is the level? How frequently they use? How much do they use? Why do they use? And those things. Then you would like to assist them to quit. The most important step is you arrange. You arrange for follow up. after talking to the person, you tell them, okay, come back and meet me in 10 days time in the OPD. By doing this, you're making them to become accountable and come back and meet you, and also tell them that irrespective of whether they quit or not, they come back and meet, because a lot of times we know when they meet us a few times is when they slowly increase their motivation and their ability to kind of fight out the withdrawal symptoms and take the necessary help. So arranging for follow-up is extremely important in these situations. So what is the brief intervention we are talking about? The brief intervention we are talking about is 5 A's. This also was asked earlier in exam. Please remember, you should ask everyone, you should advise them to quit, you should assess what is the level of nicotine use, assist in quitting, and arrange for a follow-up. This is the brief intervention we are talking about. Other than the brief intervention, we also have two major strategies. One is called as nicotine supplementation. Nicotine supplementation strategy. The other one, obviously, we have is called as anti-craving medications. Anti-craving medications. Medications which can play a role in reducing craving and managing nicotine craving. Now, what is this nicotine supplementation we are talking about? When you're talking about nicotine supplementation, what you should know is there are different forms of nicotine we have, right? There are different forms of nicotine we have. Very commonly used are gums, lozenges, and patches. These are the very common ones which are used in our country. Gums and lozenges are available as 2 mg and 4 mg nicotine. Patches are available as 7, 14, and 21 mg per day. 7, 14, and 21 mg per day patches are available. The advantage of using a patch is you put a patch, allow it to be there 24 hours, next day you change it to the new patch, so there's not much of work to be done by the patient. Whereas when they're using gums, they need to constantly keep chewing, which means sometimes they can develop oral ulcers, sometimes they can have pain, they can have jaw pain, they can have mouth soreness. All these things can be sometimes an issue. Whereas patches many times are well tolerated, except local allergy sometimes can happen. Occasionally, sleep disturbance are reported, but otherwise, patches are pretty easy to use. The logic behind using nicotine supplementation is what? How does nicotine supplementation help? See, if you take a cigarette, a single cigarette has about a single cigarette has about 4,000 chemicals in it. Has about 4,000 chemicals in it. Now, with all those 4,000 chemicals, the one which makes you become addicted to the cigarettes is nicotine. The one which makes you become addicted to the cigarettes is nicotine. So, in nicotine supplementation or nicotine replacement therapy, what are you doing? You are giving nicotine from external source. You are giving purified nicotine from the external source. Thereby, the patient might not have that much of withdrawal symptoms and that much of craving and go through this journey of quitting nicotine much more easily. That's the biggest advantage of using nicotine replacement therapy or nicotine supplementation. Understood? Nicotine replacement therapy is more official technical term, basically where we supplement the person with nicotine in purified form. By doing this, you are also giving big advantage to the patient, because you are stopping all this 4,000 chemicals exposure and just giving nicotine, which is way much more safer and better. Even in some patients, if they can completely come out of their smoking cessation, smoking to shift over to oral nicotine, what happens in them is they have reduced their exposure to unnecessary chemicals, and slowly we can help them to wean off that. So, before we go further, one of the important points you need to understand is they've also asked you in exam when you're talking about nicotine replacement therapy, especially when you're using nicotine gums, right? When you're using nicotine gums, they've asked a few interesting questions. It's also good to know. Something they've spoken about is you don't use it like any other chewing gum. There is a particular strategy we follow that is called as chew and park method. Chew and park method. what is this chew and park method? In routine bubble gums, what do? We keep on chewing, right? And swallow the juice. Here in nicotine gums, the point is you start chewing. As you start chewing, once the nicotine starts entering the mouth, it starts causing some kind of a burning sensation or some kind of tingling in the mucosal layer of your mouth. That means the nicotine levels are raising. The most important point is you don't try to swallow the juice. You don't try to swallow the juice. Why? Because if you swallow the juice, two things happen. One, nicotine absorption is less. Bioavailability of nicotine when swallowed becomes very, very less. So enough nicotine would not reach, so the medicine would not be effective. Second, nicotine can cause gastric irritation leading to nausea, vomiting sensation, or retrosternal burning and those things. So patients feel uncomfortable when they use the nicotine gums, especially when they swallow the juice. It becomes ineffective and it can cause side effects. That is one of the things we also recommend. And this was asked in exam, don't forget, about 15 minutes to 30 minutes, they should not be taking hot beverages or even water or food after using the gum. If they've used the gum now, next 15 odd minutes, they should not be taking any other fluids or food items, because if they take any of them immediately, it might deactivate the nicotine or it might take the nicotine down and cause side effects or make it ineffective. So we have to instruct the patient the right way use of using nicotine gums, because nicotine gums tend to be available over the counter. So a lot of our patients try by themselves. And they also come and tell us, sir, I tried, it doesn't work. So you should ask them if they use the right method and then help them. This was asked in exam, don't forget about it. Chew and park method is the strategy you use for nicotine gums. Then let's now talk about anti-craving drugs in nicotine. In nicotine, when you're talking about pharmacological agents, mainly we are talking about two agents. One is called as varenicline, which is the most effective medication. Other one is called as bupropion. Bupropion. Varenicline is a alpha 4 beta 2 partial agonist. Varenicline is a alpha 4 beta 2 partial agonist. Getting it? It's quite effective medication in order to reduce craving. Cost of it is on the higher side, but otherwise it is quite effective. What about bupropion? Bupropion increases the norepinephrine levels and increases the dopamine levels. By increasing the norepinephrine levels and dopamine levels, it is known to reduce craving. It's an antidepressant which does not work on serotonin but increases the norepinephrine and dopamine levels. But you should always use it in caution in patients who have risk of seizures or past history or strong family history of seizures, because it is known to decrease the threshold for seizures and lead to possible seizure episodes. So that is one drawback of bupropion, but otherwise a good drug which can be used in pharmacological management of nicotine cessation. So these are some important strategies which you should know in relation to nicotine use disorder. When you're talking about opioid poisoning, you need to understand few important aspects comes in exams quite frequently, right? Opioid poisoning. O, right? So there are three important aspects which you should know which happens in opioid poisoning. What are the three important aspects which we should know? First of all, these patients can have pinpoint pupil. They can have pinpoint pupil. Understood. Next, they can have respiratory depression, respiratory depression, or sometimes even cyanosis, blue skin, and those things. They can they can mostly be in the state of coma or unconsciousness. So these are young people mostly who have fallen on the floor unconscious. That's how when you enter the room, you will find them unconscious, non-responsive, respiratory depression, and pinpoint pupil. The moment you see this kind of a combination, you should think of opioid poisoning. And how do you treat these patients? How do you treat these patients? IV naloxone. IV naloxone is the way you actually treat these patients. Getting it? Most of the times in exam, when they ask what is the treatment for opioid poisoning, one of the choice which is given is naltrexone. One of the choice which is given is naltrexone. Please remember, naltrexone is also a opioid antagonist. Naltrexone is also opioid antagonist, but the problem is it's a oral medication. It's an oral medication, so you cannot give it in patients who are unconscious and comatose, and it takes some time to work. So all these things makes naltrexone not the choice, naloxone as the choice. So in most of the questions, both will be given. Please choose naloxone, which is the treatment of choice for opioid poisoning. Opioid poisoning. Getting it? One of the important conditions which we should know when you go for any exam is alcohol withdrawal. Is alcohol withdrawal. When you're talking about alcohol withdrawal, it's good to remember 1, 2, 3. What do you mean by 1, 2, 3? 1 day, 2 days, 3 days. Generally, within 1 day, you'll see withdrawal symptoms. Within 2 days, what do you see? Within 1 day, you see withdrawal symptoms. Within 2 days, you see withdrawal related seizures. Withdrawal related seizures. Within 3 days, you generally see delirium tremens. Delirium tremens. Within 3 to 5 days, they say, but easy to remember 1, 2, 3. Withdrawal symptoms within a day. Within 2 days, mostly seizures can happen. Within 3 days, delirium tremens can happen. Now, breaking it further, when you're talking about withdrawal symptoms, please remember within the first 12 hours, less than 12 hours, you can start seeing symptoms. The moment the person has had alcohol, last drink is about 12 hours back, they start having withdrawal symptoms. What kind of withdrawal symptoms they start having? Tachycardia, increased sweating, insomnia. Very commonly, they can have what we call as rebound REM phenomena. They can have what is called as rebound REM phenomena, again tested in exam. What is this rebound REM phenomena? Rebound REM phenomena basically means alcohol is a suppressant of the REM phase. The moment you stop alcohol, there is an increase in the REM phase. That is called as rebound REM phenomena. Clinically, these patients will present with a lot of nightmares. These patients will present with a lot of nightmares. That's how they present. Understood? Getting it? What else can happen? Tremors can happen. Tremors can happen. And again, you need to remember tremors is something which is very, very important feature you should pick up in alcohol withdrawal. Within 12 to 24 hours, within the first 12 hours, you see all of these things. Within 12 to 24 hours, perceptual problems can happen. What problems can happen? Perceptual problems. When you say perceptual problems, what's the common perceptual problem you can see? You can see a lot of patients developing auditory hallucinations. Patients develop auditory hallucinations very commonly. Understood? Auditory hallucinations as a perceptual problem very commonly. In fact, a lot of patients with alcohol use quite frequently can have very frequent, especially auditory hallucinations. That condition is what is called as alcoholic hallucinosis. What is alcoholic hallucinosis? As the name says, in people who are constantly drinking alcohol, right, over a period of time, they can, as a part of withdrawal or as part of regular use of alcohol, they can start developing alcoholic hallucinosis, which is mostly auditory hallucinations which happen, and these patients with alcoholic hallucinosis will also have clear sensorium. Clear sensorium. There'll be no altered sensorium. They'll be having clear sensorium. That's very characteristic of patients with alcoholic hallucinosis. Again, tested in exam. Alcoholic hallucinosis patients will have auditory hallucinations and clear sensorium. That's also something which has been tested in exams, and don't miss it. Within the next 2 days, what can happen is seizures, right? Here, most of the times, what you see is generalized tonic-clonic seizures, generalized tonic-clonic seizures, and most of the times, these patients will have clusters of seizures. Means what? Back to back, back to back. They'll come and tell, sir, from afternoon he's have 10 episodes of seizures, 5 episodes of seizures. Like that, clusters of seizures are very common, and most of the times we are talking about generalized tonic-clonic seizures in these patients. Within 3 days, generally, you can see patients developing delirium tremens. Delirium tremens. And please remember, delirium tremens is an emergency condition. Very, very importantly, what happens in these patients? There will be altered sensorium. They can also have auditory hallucinations, but more commonly, what you see in these patients is visual hallucinations are more common. One of the important things which can happen in these patients is called as Lilliputian hallucinations. Lilliputian hallucinations, again, a stock question which has been asked in the past. What is this Lilliputian hallucinations? Lilliputian hallucinations means you see human beings, birds, people, insects, everything small, small, small. You'll have visual hallucinations where everything is looking very, very small. That is what is called as Lilliputian hallucinations, which can happen in these patients with delirium tremens. So in delirium tremens, as I told you, they'll have visual hallucinations and they'll have altered sensorium, which is little different from the other condition which I just spoke to you a few minutes back, where alcoholic hallucinosis typically will have auditory hallucinations and clear sensorium. Understood? Now, one more important point you need to understand is when you have only these symptoms of withdrawal, right? It is called as simple withdrawal. Simple withdrawal of alcohol. The moment they have psychotic symptoms, seizures, or delirium, it is called as complex withdrawal symptoms. Complex withdrawal. What is simple withdrawal symptoms? They have simple symptoms: tachycardia, increased sweating, increased blood pressure, insomnia, those kind of things. The moment they have psychotic symptoms, they have altered sensorium, they have seizures, it becomes complex withdrawal symptoms. The most important point we need to understand is, irrespective of what kind of withdrawal happens, benzodiazepines remain the treatment of choice for managing Benzodiazepines remains the treatment of choice for managing alcohol withdrawal. Benzodiazepines remains the treatment of choice. Any benzodiazepine can be given, but in patients with liver dysfunction, it is preferable you try LOT. Why? Because it will not get accumulated and lead to respiratory depression. That's why you can preferably try lorazepam, oxazepam, temazepam. Lorazepam, oxazepam, and temazepam are preferred because they don't get accumulated in the body and they are very short acting, so they do not cause that much of respiratory depression. That's the reason it is preferred in elderly people and people with liver dysfunction. So, when you're talking about alcohol, it's also good to know about aversive drug and anti-craving drug. With that, we'll come to the end of the video. In aversive drug, what we should know? The point you should know is disulfiram. The drug we are talking about is called as disulfiram. Disulfiram is an aversive drug. It is a irreversible aldehyde dehydrogenase inhibitor. It's an irreversible aldehyde dehydrogenase inhibitor. What does it do? it increases the level. It increases when a patient is on disulfiram and takes alcohol. It increases the level of what? It increases the level of histamine, serotonin, dopamine. Of course, it increases the level of aldehydes. That is what is called as disulfiram ethanol reaction. That is what is called as disulfiram ethanol reaction, which can happen. Understood? Please understand, disulfiram is a drug which can be started 12 to 24 hours after the last drink. 12 to 24 hours after the last drink, you can start disulfiram safely in the patient, because liver status is important and liver status can be quite commonly affected in alcohol patients. It is always good to get liver function test done before we think of starting disulfiram. Disulfiram is always started in people who are quite motivated and willing to take after their consent. Only it should be given. You don't give it without the knowledge of the patient. It is given with good motivated patients who are consenting to take it. Next important point you should remember is disulfiram can continue to work for 1 week to 2 weeks, almost even after stopping disulfiram. If I leave, see, let's imagine it is December 31st, the patient thinks, okay, year end, I want to drink today, so they don't take the medicine and go and have alcohol. They still can have reaction because it can still be effective for about a week to 2 weeks. The new enzymes have to come, right? Because it's an irreversible inhibitor. Till the new enzymes come and recycle, it will, the effect can still remain. So you should caution the patient that if they stop medicine and still go and drink within 1-2 days, they can end up having disulfiram ethanol reaction. That's something which we should inform patients. Always cautiously use disulfiram in patients with peripheral neuropathy, and psychosis patients, because it can worsen peripheral neuropathy and psychosis. So that's why you should be careful about using in this particular population, peripheral neuropathy patients and psychosis patients. How do the patients with disulfiram reaction present? Disulfiram reaction patients will come with nausea, vomiting. Very importantly, they can have hypotension. They also will commonly present with flushing, very bad odor, garlic kind of an odor, onion kind of an odor can come out of their mouth. That's how they present. It's a good treatment strategy in patients who are well motivated and willing to completely quit alcohol. It's a good medication to consider, disulfiram, which is an aversive drug. The last point we need to remember in this video is we are talking about anti-craving drugs. They've asked multiple times in exam, what are the anti-craving drugs you should remember? You can remember this simple acronym, ANTSOB. ANTSOB, acamprosate, naltrexone, topiramate, SSRIs, ondansetron, baclofen. These are the anti-craving drugs you should know. These drugs do not react with alcohol but reduce the craving and urge to take alcohol. The biggest advantage of this is here the patient doesn't need to stop the medicine even if they by chance start drinking. If they continue the medicine, maybe the chances of getting into binge drinking and other things might come down. So in those patients who are not looking for complete abstinence, these are much more safer alternatives than disulfiram. Understood? These are important anti-craving drugs you should know. With this, we come to end of this video. Best wishes for your exams. Thank you very much.